premature death, very premature death, death before birth. But the problem is, once you're born, you got stuff looking at you from the other side. And people had thought for a long time, well, this is not going to be a major issue. It is a major issue. It's creeping toward us, and I think it's vital that we look at both ends of the life spectrum. The most important spectrum, I think, right now for all of us, since, as Ronald Reagan once said, everybody that is for abortion has already been born. Well, everybody that could be affected with medicalized killing has already been born. And we're all slowly or quickly dying at some point. You know, some people say you start dying the day you're born. Well, that's a little pessimistic way to look at it, but we'll not go there. Let me just get into the talk. So the talk is End-of-Life Issues and Medicalized Killing. And I wanted to spend a little time laying the groundwork, telling you what medicalized killing is all about, end-of-life issues, and some ways that we deal with it, both from a medical standpoint and a medical ethical standpoint. I've been involved in the bioethics committees since St. Vincent formed a bioethics committee, and then I was, I won't say dragooned into the Diocese Moral Medical Advisory Board, but I ended up ultimately chairing both of those. All that means is I was willing to show up early and, you know, pass the peanuts around. So, without further ado, we'll talk a little bit about medicalized killing. It's a sort of a bizarre term, you don't hear about it that often, but it covers both aspects of what we're talking about tonight, euthanasia and assisted suicide, or medically assisted suicide. People like to clean it up by using euphemisms, by using acronyms, and we'll be getting into that. But euthanasia is directly killing a patient, or a person if you like, but I look at it from a medical viewpoint, from a physician. If I were to kill a patient, that would be a euthanasia. Physician-assisted suicide, on the other hand, a healthcare provider assists in the patient taking his or her own life. So we assist their suicide usually by prescribing lethal amounts of commonly available medications. So neither one is acceptable on a moral code, so both of them are horrible. But they have slightly different ramifications, as we will see. Now, in addition to the two major types, there are 4 categories you have to keep in mind. Active euthanasia or assisted suicide, an action which directly ends the patient's life. So if I go in with a syringe full of potassium injected into the patient's heart, obviously that's active euthanasia. Going in with a gun would have the same purpose, a little bit less neat. Passive euthanasia, withholding life-sustaining therapies, hydration, nutrition, with the intent of causing the death of the patient. The important word here is intent. Okay, we'll get back to that because that's a very important distinguishing factor and something I had been confused of when I even started practice, and I had to learn this the hard way. And then there is voluntary and involuntary. Obviously, the patient gives consent or does not give consent to the medicalized killing. You would think, well, who in the world would do involuntary euthanasia or involuntary suicide? And the answer is the Netherlands is doing it right now, and there are a variety of other countries that are contemplating or actively proceeding with involuntary active euthanasia and other forms of offing people. So it's a horrible thing to contemplate, and we'll talk a little bit about that later. We've got some slides to show you how bad the problem has become. So the scope of the problem, Netherlands, of course, they are the bellwether. They're the first ones to get involved in this. And in 2020, they allowed almost 6,950 people approximately that were reported. Remember, reporting doesn't always follow what's actually going on. So we know a minimum of 6,930 patients in 2020 alone. Canada in 2015 allowed medically assisted aid in dying, MAID. So you don't have to say medically assisted dying. So they made up the acronym MAID. I would love to know who in government gets paid to make acronyms, but man, they are busy as all get out. So in 2020, there were 7,500, almost 7,600 cases in 2020 alone compromising 2.5% of the deaths in Canada that year. That was last year, 2 years ago now. Increase in 34% over 2019. So the numbers are skyrocketing. And total deaths in Canada since enactment, 21,589, and that's only since 2016. Every year we're going to see the growth going up. So it's getting closer and closer and closer. How close is it? Well, here's some ideas. Now you can't quite see everything on this slide. If it were a little bigger, a little brighter, but I will tell you, the red, non-hatched are euthanasia is illegal. Blue, dark blue, active euthanasia is legal. So we have Canada, let's see, Venezuela, of course the Netherlands, Luxembourg, Japan, South Korea, and passive euthanasia is legal in India, much of the Middle Corridor, Ireland. So there's a lot of things going on around the world, Australia. And this isn't only a slide from a few years ago. There's a number of other problems going on. Now, this is assisted suicide alone, but it shows you that it was legal before 2015. The dark, lighter purple is legalized after 2015, and the blue in here, over there in Australia, these are countries that are contemplating it and probably have passed it by now. We have now 8 states plus the District of Columbia that are good with legal assisted suicide. In other words, they're permitting it, and there are others looking at this. Notice it's starting on the West Coast and it's moving its way toward us. Starting in Washington, Oregon, California, moving over, and of course the East Coast has to get into the act, New Jersey, Vermont, Maine. So it's coming our way, and it's not a pleasant thought to believe that you can just request it, somebody can give you a little bottle of pills, that'll be it. It's inconceivable. As a physician, we're supposed to care for the patient as they're living. We're not supposed to be killing patients or assisting them with dying. That's totally contrary to everything we've been taught, and you really don't want to have a physician supposed to be caring for you on one hand thinking, well, maybe he'd be better off going to the other side. That's really, you don't want to cross that line. You don't want to have your physician thinking that, and as a physician, I certainly never want to be thinking that. So, medicalized killing in the Netherlands. In 2003, it's below 2,000. The dark purple line is euthanasia, the assisted suicide is the little yellow, and the red line shows the combination. Notice it's on a significantly upward trajectory. It's tailing off a little bit in 2015. That's the latest I could find on a slide, but it gives you some idea of how rapidly it took off. And the vast majority of these are euthanasia. In other words, somebody had to actively go in and kill the patient with medication, or passively do it by discontinuing hydration, nutrition, or ventilation on a patient with the intention of killing that person. So that's an important distinction, as I mentioned. And this just gives you another idea of the suicides per 100,000 population on the bars, and the euthanasia-assisted suicide is a percent of all deaths, reaching close to 4%. That's the little reddish line. Close to 4% of the Netherlands population, or let's see, 35 per 100,000 deaths. That's a large, large chunk of people being killed by your own medical establishment. This one I found very concerning. I read a book, or at least a third of a book, I couldn't get through it all, called The Nazi Doctors. And it was all about how physicians dealt with the getting rid of what they called useless eaters in Nazi Germany. And they had a panel of 3 physicians, and each one would have to put a plus or a minus. Plus means, yes, I agree that we should terminate this person, and a minus would mean no, let's not. Well, once the first plus is on there, second and third, you just don't negate what's already been started. So it was very rapid. Now, this shows the amount of time per case that was used to contemplate whether this person should be allowed to have euthanasia-assisted suicide. Over here, 2002, you're talking about over an hour, less than an hour. About 2009, goes down to minutes per case. 60, 50, 40, 30, 20. By 2016, they're spending less than 20 minutes reviewing a case, reviewing all aspects of the case, before deciding whether it would be valid to allow someone to kill themselves or to directly kill. That's a very short, believe me, I couldn't read the patient's history and physical alone in 20 minutes, rather than go through all of the information that would be necessary to make a decision like that. So that's just telling me people aren't paying a lot of attention to this. They're doing it as a matter of rote. Somebody says it, sure, no problem. Off you go. So why would somebody choose to die voluntarily? Well, first, I think, is what has been called justice, or it should have been justice. Robert Bork taught me the term radicalized autonomy. In other words, I'm the boss of me, nobody else is. I get to say what goes. Everything that I want, I should be able to decide, no holds barred. Okay, so radicalized autonomy. It's me, me, me. There's nothing above me. I'm my own God. That's a major problem in this country, and it's getting to be far worse. And of course, fear of suffering. And I put in suffering purposefully, not just a fear of pain. Pain is only one aspect of suffering. Suffering encompasses a whole wide range of problems. And when you deal with ill patients, or if you deal with a loved one who is ill, especially one who is dying, you know that there's a wide range of non-pain related suffering. Worrying about medical costs, worrying about who's going to take care of me. I've got another slide on this later, but all sorts of concerns. And this is suffering, and it is a real problem. If we do nothing to address this, the number of requests for suicide and euthanasia is going to be great, and it's going to be greater. Fear of being a burden. Anybody here worry about being a burden? Yeah, I already am a burden, but that's my wife, that's her. She signed up for this. But yes, people really think about this, and we are very happy to take on those burdens of our loved ones. But the loved one doesn't always reciprocate. Just don't want to do that. But I feel that it's a part of our Christian duty to give when we can give, but to receive graciously when we no longer can give and when it's our turn. We've got to make it easy on these other people. And then cost of ongoing treatment of care, or treatment or care. Very important. People don't want to, they saved up hundreds of thousands of dollars, they wanted to put their grandchildren through college. All of a sudden they've got a disease that's going to drain their bank accounts, cause them to sell their homes, and they're still not going to survive. So what are they going to do? So there are alternatives, and we need to address those. And again, this codifies it. I'm sorry that slide is blurry to begin with. You can't really see that, but 82% loss of ability to engage in meaningful life activities, loss of ability, the second line, to avoid activity, to perform activities of daily living, inadequate control of symptoms other than pain. Fourth line, 50% inadequate control of pain or concern about that. So loss of dignity, perceived burden on friends, functions, loss of control of bodily functions. These are all significant concerns. Anyone who has dealt with a dying person or a seriously ill person knows all of these factor in. But 80% of people worry about not being able to do anything meaningful with their lives any longer. And over 50% are concerned about suffering and pain, 70–80% in cases. So we need to be able to address these. Everybody knows this guy?
Oh yeah.
Jack Kevorkian. The person who popularized his suicide machine. You've got a book on him over here, I saw. He was in, I think, Michigan, and he actually hooked people up, got tried, and I don't remember whether it was, yeah, he was eventually, I think,
went to jail.
Yeah, he did go to jail for it. He eventually died, and I don't know whether he took his own life or not, but he was the guy who he was the first major popularization figure for it. So just wanted to bring up his face, just to keep it in mind. You know the mind of your enemy. Is it Cal Thomas once said at a pro-life meeting that every day he read the New York Times and the Bible so we can get both sides of every issue. So let's talk a little bit, now that you have a little idea of the background about what we're talking about in medicalized killing, let's talk about end-of-life issues, because end of life is an important aspect. Everybody here is alive. Everybody here is going to die. We need to understand that it is a normal part of life. In fact, it is the last aspect of life. It is the last act, if you will. And it's a process. And as I said, many of us, being a little bit older, are coming closer to it than perhaps others. It's a process. Now, we are not all actively dying. But every day I find there's something not working quite as well as it did before. Every day there's another couple of gray hairs. This half is Antonia, this half is Nicholas. I got 2 other kids, they didn't give me any gray hairs. But you know, dying is a process, especially when you're actively into the point where death is more or less inevitable. It may be slow, it may be quick, but it's going to take place. But death itself is a line. It is easily definable, and sometimes not so easily definable. But up until about 40 years ago, it was very easily definable. People stopped breathing, the heart stopped pumping. Now, it can be a little more complex than that. But it's important to realize that dying is a process, because you can intervene in processes. You can make changes. You can make the process more comfortable, or you can make it less comfortable. It really depends on what your focus is. Wasn't it Barack Obama who talked about the 95-year-old woman with a zest for life who might have needed a pacemaker, and a woman stood up and asked President Obama, well, she's 95, she has a great zest for life, she needs a pacemaker, will we allow this under Obamacare? And he spent the whole time talking about, well, you know, what about, you know, she may not be this, she may not be that, it might be just better to give her the pill. Now, I don't know whether it was just a pain pill or whether he had something else in mind. It really wasn't clear, but it was very clear. Number one, he wasn't going to answer the question. And number two, he felt that after a certain age, maybe we shouldn't be spending those precious resources on somebody the likes of you. Watch out. Politicians are coming. So, what is death? As I said earlier, cessation of vital functions. Respiration and cardiac function were the clear ones. No pulse, no circulation, no breathing. You're dead. Okay? That was easy until we got reliable ventilators, until we got good resuscitation, and we have cardiac resuscitation techniques, we have heart pumps, we have all sorts of other things that can dramatically extend lives. It can also dramatically extend the dying process and make it even more complicated. So persons sometimes do require long-term artificially administered ventilation, cardiac support, and of course when they go on for long enough, we need to start supplying hydration and nutrition as well. How do we tell when people like that have actually died? Well, fortunately there are ways. So up until about 40 years ago, this was a vanishingly rare problem because you didn't have people living who didn't have any brain function, because respirations are of brain function, whereas the heart can pump without any brain whatsoever. That's why we could do heart transplants, because the heart pumps on its own. Give it blood, give it a little shock, it continues to pump. May not be quite as efficient, but you don't need any brain function for that. Respirations, on the other hand, are driven by centers within the brain stem. If those are permanently damaged, you're not going to be breathing again. So, because we have ventilators, because we have cardiac supplementation and ability to bring people back from cardiac arrests, we needed to devise what are called brain death criteria. So the bodies can be supported beyond the capability of the brain to ever recover. So brain death is death. You don't have to say brain death. We don't talk about heart death or breathing death or decapitation death. Well, maybe we do, but we don't. But it is death as much as irreconcilable cessation of circulation or respiration. It's 7 o'clock, by the way. Thank you. Time for my drops. All right, but I wanted to spend a minute or two, because this is what I did for a living. Not exclusively this, thank goodness. That would have been really dreadful. Oh yeah, I saw 2 more dead people today. That was a bad day. Determination of permanent cessation of function of brain and brain stem function. Now, that doesn't mean that every cell from the neck on up had to be dead. It meant that the brain and brainstem could no longer function in a whole, and it will never function as a whole. There would be cells that might survive days, but because it's no longer functioning in any meaningful way, it can no longer drive respirations, it can no longer perform any other functions, that person will have died at that point, that we could make that determination as surely as if their heart had stopped and we couldn't restart it, or they stopped breathing and we couldn't restart the breathing. It is rigorously determined with evaluations utilizing physical examination as well as diagnostic testing if necessary. Lack of brainstem reflexes, we test for breathing very seriously because that is the sine qua non. That is the thing that we look for. If somebody cannot breathe and all the other brain and brainstem functions are gone, that person has died. And that there's no other cause of unresponsiveness. We make sure that the blood sugars are good, that they're not on any sedating drugs, that the body temperatures are correct. We rule out any other extraneous cause, because if you look at it and you leave this out, every person who goes under general anesthesia is dead. But they're not, because we know we can wake them up. Our son underwent it a week ago. So he's awake, he's alive. He's not quite kicking butt, taking names, but he's getting it. So they supplement with EEG, angiography, transcranial Doppler. So we have supplemental tests, but it's still a clinical diagnosis. We examine the patient very carefully. We have very carefully spelled out criteria. We're not going to go through it. Anybody know who this smiling fellow is? Because he only has 10 more years on this planet, according to him. This is Dr. Ezekiel Emanuel. And he proclaimed in an editorial in, I think, the Wall Street Journal, but also published in the New York Times, that anybody at 75 or over, he's certainly planning on doing
no, wait. We're
Hi, come on in. Oh, that's okay. There will be a 10-minute period, so you don't have to sit and listen to the first half of the talk. Okay. He proclaimed a few years ago that at age 75, he fully intends to no longer take any medical care, and he feels that everybody else should follow his example. In that case, our president should probably have stopped taking medical care 3 years ago. But he's presently 65 years old. I will be very, very interested in 2032, when I'm going to be even older than he is then, to see whether he indeed follows through with that promise. And he was adamant about it, because, by golly, you're wasting money. He was also one of the big founders and big writers of Obamacare. You notice the trend going on here?
What's his name again?
Ezekiel Emanuel.
Brother of?
Brother of Rahm Emanuel, who was former, the chief of staff for Obama, former mayor of Chicago. Notice a lot of formers. Okay, so let's talk a little bit about care for the dying. Now, I'm not talking about just chronically ill. I'm talking about people that have a diagnosis that will ultimately indicate that they're going to die relatively quickly, okay? My wife's sister received a diagnosis of stomach cancer, which was already grade 4, stage 4. We knew that within a year, maybe 15 months at most, she was no longer going to be with us. Her son is an oncologist, and he said, we'll have her for this Christmas, but we're not going to have her for next Christmas. Unfortunately, that was correct. However, she was then able to make great use of that time. She had her daughter, she planned the daughter's wedding. She said it's a lot more fun to plan a wedding than a funeral. And she died about a month before the wedding. And she pretty much planned every aspect of that. So it's very important to recognize when people are dying and what their goals are, and to assist them in those goals. So, talking about medical care for the dying, on the other hand, the old terminology which we've all heard of is ordinary versus heroic care. Believe me, none of us doctors wear spandex, we have no big S's on our chest, we don't jump in, aha, I'm going to be heroically caring here. No. But the terminology used to be ordinary versus heroic. Well, that was very vague, so we decided to try to use some new terminology. Ordinary versus extraordinary means of care, but unfortunately, that has different meanings in philosophy and medicine, so we came up with proportionate versus disproportionate means of care. And I'll define these for you, because it's very important to understand these when you're talking about end-of-life issues and you're talking about people who are potentially looking to end their own lives. So I feel that it's very, very important to understand what physicians are talking about, and I drew a lot of this from Catholic medical moral teaching. And you have to understand that Judeo-Christian moral medical theory and teaching has been going on for 5,000 years. So we've been receiving the ongoing and collected wisdom from people from the ancient Jews on through the most rigorous thinkers of today. And it's a very useful, it may not be the only way to look at it, but a lot of people draw from Judeo-Christian medical ethics because it is so comprehensive. So a lot of what I'm saying, I'm a Catholic, so I'm going to be talking about that aspect of things. There may be other ways of looking at it. So ordinary or proportionate care. It is proven to be successful. It is customarily used, okay? Penicillin for pneumonia, for instance. Reasonable hope of benefit. The majority of people who receive that care are going to benefit from it. And without imposing disproportionate burdens. Remember I was talking about those patients' concerns? Okay? If it's going to be extraordinarily painful or too expensive for, any variety of reasons, the patient gets to decide what might be a disproportionate burden. And again, we'll get to that. This is pretty complex, and I'm moving through it pretty quick, but proportionate means of care, and it also means that those means do not involve any grave burden for oneself or another. In other words, the patient or another person who is responsible for the patient doesn't involve any grave burden. If you're in the middle of Africa, okay, on the veldt somewhere, and you need a blood transfusion or dialysis, that's a very disproportionate burden because they don't have those means there. If you fall down in the middle of Chicago or here in Erie, we have those means. Very easy to get to. That is proportionate. If it is extraordinarily difficult to get to, it becomes disproportionate. And according to the circumstances of the person, places, times, and culture. Some cultures don't believe in certain things. Jehovah's Witnesses will not take transfusions. An entire cottage industry has come up with minimally invasive surgery, minimal bleeding surgeries, autotransfusions. Sometimes they will take them, sometimes they won't. But people have, physicians have figured out how to make this work so that that belief system can be catered to without giving them an undue burden, but allowing them to benefit from care. So what, on the other hand, are extraordinary means of care, disproportionate? Of course, it's just the opposite of what we're talking about. It's not proven to be successful. In other words, potentially an experimental treatment, one that has not been rigorously proven, or it is not customarily used. Again, experimental treatments. Not a reasonable hope of benefit. One time out of 100, one time out of 1,000. There's a new cancer therapy. It might help you, one time in 100, one time in 1,000. Okay, that's not a reasonable hope of benefit. There's an outside chance. Some people are really clinging to life. They really want this, but some don't. Or it imposes a disproportionate burden. So we are all obligated, and again, this refers to healthcare givers as well as family, as well as friends, as well as anyone else. We are all obligated to provide proportionate care to all persons. Disproportionate care, on the other hand, is not obligatory. However, a person may choose to take care that what might be considered disproportionate, depending upon the person and what they want. So, for instance, what would a disproportionate care be? Somebody who's actively dying has a limb that circulation's gone, is becoming gangrenous. You could remove it. It's not going to add anything whatsoever to the patient unless it's causing tremendous pain, in which case then it becomes more proportionate. But a disproportionate treatment would be one in which it's not going to really alter the outcome of the patient. In other words, not going to save their lives, not going to extend their lives meaningfully, not going to benefit the person in any meaningful way. Somebody who is 27, 30 years old, has a gangrenous limb, yeah, you're going to get rid of that limb because they may have 30, 40, 50 more years. So circumstances really define a lot of this. So any type of care may be proportionate or disproportionate depending upon circumstances. Think about that for a moment. I had a perfect example when my father was dying. I was very fortunate to be able to be with him his last day or two. He had cancer of the lung that metastasized to his liver. He took chemotherapy, got better for 5 years, beat all the odds. Well, he was a gambler. So the cancer came back after 5 years. He lived long enough to get prostate cancer and a broken hip. But eventually the lung cancer caught up with him. Took another run of chemotherapy, wiped out his white count. He was in the hospital for 4 to 5 days, and it was just too hard on him. I spoke to the oncologist, and he said, you know, the next course will kill him. So I told my father, you know, Dad, there's nothing else you can take. This is it. He said, are you sure? I said, Dad, trust me. Little white lie, but I did not want him to undergo a worse death than he was going to suffer. He had become finally comatose. He was on his deathbed. We were giving an IV morphine drip to control his pain, control his other symptoms. I was with him. We came in to see him. He lived around Philadelphia. We were up here. We were able to drive in. We were able to be with him his last day. He was pretty much unconscious. At that time, my son, who weighs now 265 pounds, was 18 months old. I was able to pick him up and put him on my father's chest. Dad, Dominic's here. He woke up for that. He loved my son. Really thought. He said, I can't get over that kid. I said, well, you shouldn't. But he woke up for that, and then he was back in a coma. Every 2 hours, following normal, proportionate care for almost everybody, the nurses and the techs would come in, percuss his chest to move any phlegm around, and rotate him from side to side to prevent pressure ulcers and to prevent the likelihood of his developing pneumonia. For anyone else, that would make sense. My father was quiet and comfortable until every 2 hours when they came in and they did that. They would pound on his back and he would cry out in pain. They would roll him and he would say, no, don't. It's the only time he woke up. After I saw this once or twice, I just asked him, please, I know it's normal, I know that's our usual care for patients. He's dying. He's going to be dead in a few hours. Doesn't matter whether he gets pneumonia or that will kill him in 2 days. He's going to be dead of his disease within 12 hours. They left him alone, and he died quietly, without any additional pain, without waking up again, to my knowledge. Because he made it through the next morning. It was a beautiful morning. The sun was coming up. It was over a creek. It was beautiful. And my dad, you know, he's stubborn. He might have stuck around for days. And I told my family, listen, let's just rotate in shifts, go home, catch a shower, grab some food, bring it back to the people that are still there. My sisters and I left, leaving my older brother and my mother there. We got home. 5 minutes later, we get a call. There's no pulse. My father knew, you know, didn't want Abby to leave, didn't want my mother to leave, so he decided to die there. But he died quietly and peacefully. A good example of when proportionate care becomes disproportionate, when it is an undue burden to the person, and no person is obligated to receive disproportionate care. So that just goes through this again. Again, for extraordinary means, patient may elect to forego treatments, may be abandoned at any time once it's begun. So something that was worthwhile or proportionate initially may become disproportionate later. You may discontinue that. Somebody once said, anything that is once started may be stopped without any undue problems. Well, marriage is one example where that's clearly not the case. You know, you can get into it, you can get out of it, but it ain't pretty. And comfort measures which unintentionally hasten death may sometimes be permissible. We're going to talk about that in a little bit of detail because that is very important. Any idea who this fellow is? This is Peter Singer. He is a so-called bioethicist. I believe he's at Princeton now. This is a fellow who has said that not only is abortion okay, but infanticide is okay, and in some cases good up until the age of 5. He also is saying that as long as a person doesn't, you know, once a person loses their cognition and all of their understanding, they're no longer human beings. However, his mother somehow didn't come under that rubric. When his mother developed severe dementia, he was making sure that she got all the care that she required. So, know thine enemies. He's at Princeton. He's being paid a princely sum to teach undergraduates at Princeton direct like that. So, I wanted to talk for a few moments about one of the major ethical, moral tools that we use to try to determine what's going on. And this is also important to me because I had to learn this at the bedside. A very wise oncology nurse helped me through this and helped me understand it. Okay, this is the principle of double effect. It's been around in one form or another since the 13th century. And it is, I think by this point, very well worked out. This is what allows us to eliminate pain and give comfort measures and comfort treatments that otherwise would not be appropriate. And this is specifically, in this case, for a dying person, but it can be used under other circumstances as well. So it is a paradigm to be used to help you decide whether an action is moral or illicit or not. So it allows you to properly judge whether it's good or not. And the action can be foreseen to have a licit and an illicit or a good and bad effect. And I'll give you examples because this is sort of high-toned language, but it allows you to fully understand what we're talking about. So the action that the person wants to undertake is foreseen to have both a licit and an illicit effect. So the action itself, these are the four categories that have to be fulfilled in order for the principle of double effect to come into action. So the action itself is either good or morally neutral. In other words, killing a person is never morally neutral. That one's out. No matter what else follows, killing a person is never allowed. The good effect, and not the bad effect, is intended. I think this is the most important thing. What your intention is defines whether your action is morally allowable or not morally allowable. The good effect is not produced by the bad effect. You can't say, I'm going to put this person out of his misery and then his pain will be gone. No. That's the wrong way to look at it. And there is a proportionally grave reason for permitting the bad effect. So there are some other criteria which have been debated. Good effect must be the least harmful alternative. Good things to think about, but not as critical. And the good effect must follow as immediately as does the bad effect. In other words, you can't have the person die first and then 3 days later the pain is relieved, something like that. But okay, so a good example of this is a dying person, and this was the case that I had. A young man, he was a junior or senior in high school, came in over our Christmas party with seizures. Turned out to have a huge brain tumor, inoperable, untreatable. We were able to shrink it down some with steroids. He lasted until July, August, something of that nature. So he lasted maybe 8 months. And he was having more and more and more pain. There was nothing more we could do. Surgery wouldn't help, radiation wouldn't help, chemotherapy was ineffective. The tumor continued to grow and grow and grow, gave him more and more pain. I became very concerned about giving him so much narcotic that he might stop breathing. That's where the principle of double effect kicked in, and then the oncology nurse taught me about this, said, that's okay. And I went and read about this and said, damn, why didn't they tell me about this in medical school? And they should have, and now they are. But this was in the 1970s. I went to medical school. They weren't quite as sharp on medical ethics then. They're getting better now, but now we're seeing both sides of the aisle being played in some schools. So, what are narcotic analgesics? Morphine. Okay, easy one to think about. Codeine, things of that nature. Probably our best tools for combating pain. Excellent drugs for pain, but has a number of other effects. Among them is reduces respiratory drive. So if somebody takes morphine, they may not breathe quite as well. And we know that to be the case. It resets your ability to react to carbon dioxide, you don't breathe as well. Somebody who might already have compromised breathing, like my father with lung cancer, and he had COPD, he smoked like a chimney, 150 pack years, he may not be able to exchange air very well. You reduce that drive a little bit, he's going to die from that. But if he's having pain and he's actively dying, it is more important to get the good effect, pain relief, and the foreseen but unintended effect of the person dying sooner than they otherwise might have would be then morally acceptable. Okay, it's not ideal, but it's the best we can do. It's better to have somebody have pain control, which is a big concern for people who are dying, pain and suffering control. Remember, 81% of 50%, 60%. More important to control the suffering and the pain than it is to have them live another couple of days, maybe a week, something of that nature. With my father, it was a matter of hours. But it was still, if the person expires a little sooner than without the narcotic, that's an acceptable use and an acceptable example of the principle of double effect. So the action is good in itself, pain relief, relief of suffering, and suffering can be defined, and it's important that the patient define what suffering is. I can't get up and go to the bathroom myself, or I can't pet my dog, or what have you. Exactly. So all sorts of things. I'm sorry, this is a pretty complex slide, but the action has to be good. It concerns the object of the action. Some actions are objectively wrong, like killing somebody, never allowable. Or an action that is wrong by nature cannot be justified, such as killing, slavery, degradation of the human person, sexual slavery, prostitution, things of that nature. The double effect isn't only used for dying, but there are other aspects where you've got to always be sure that the action itself is good or neutral, but never evil in intent. So the bad effect is foreseen but not intended. This is where intention becomes so important. Because if I go into a room with a syringe of morphine and I give it to the person, I'm thinking, good, I'll put this person out of his misery. That's illicit, that's immoral, that's inappropriate. If I go in and I'm saying, I'll give this person enough to control his pain, but if he stops breathing, we're not going to resuscitate him because we asked him ahead of time, he didn't want to be resuscitated. But it's okay because we are controlling his pain. If he dies, he's going to have died anyway, perhaps a day or two later, but without pain is always good. So if the intention is illicit, the action is illicit. If it's okay, and it's dealing with the intention of the action, it really depends. It's the same action, it's the same drug, same circumstances. What goes on in here determines whether that's a moral act or an immoral one. And again, no evil means to a good end. Removal of a healthy organ or a body part, like patients with body dysmorphic disorder, or now we're seeing these poor kids that are being convinced that boys are girls and girls are boys, and let's chop you up before you're 12 years old, and turn a hole into a hole and all the rest of that. It's terrible.
Could you explain body dysmorphic?
Sure. A body dysmorphic disorder. We had a case, I think it was in England a while ago. Person believes his leg is diseased and is in terrible suffering because he believes his leg is diseased, although every test known to man shows the leg to be perfectly sound. Is it right to remove that leg and have that person with a psychiatric disease then believe that the diseased, in his mind, limb is then gone? That's a body dysmorphic disorder. Okay? Sexual dysmorphic disorder is very similar, where a male believes himself to be a female, and then surgery gets done in order to conform the gender. Let's not open that, but patient desires removal of a healthy limb because of the belief that the limb is diseased or undesirable. That is not allowable, certainly not in Catholic healthcare institutions. I think that that's morally a reprehensible choice by any physician. And selective abortions in multiple pregnancies, another good example of removing, in this case, healthy fetuses. With Clomid and other fertility drugs, you could end up with 5, 6, 8 pregnancies. Or when you're doing in vitro fertilizations, they'll often implant 2, 3, 4 embryos and then selectively cull the ones that don't look like they're going to make it quite as well. Morally illicit. My point of view, I hope that your mileage doesn't vary. So proportionate reasons, saving a life, pain relief, relief of suffering, very important proportionate reasons because we're talking life and death under these circumstances. So, there's one other guy. Why is he smiling? This is Paul Ehrlich. Paul Ehrlich has been wrong on every major thing that he has ever done in life. He wrote a book in the 1960s, 70s called The Population Bomb. And he convinced large swaths of people in the Malthusian belief that our population was going to get so large that there was going to be widespread mass suffering, massive starvation, people were going to be killing each other, and that this was due to take place sometime in the 1990s. Anybody ever notice anybody, dying of famine? Just the opposite. He is still a professor. He is still making money on this book. And he's been wrong on everything that he has predicted. So why shouldn't he smile? So I've got other things that I could go into, but I think we're going to hold it right there. I'm going to show just one or two little summations. So what can we do to support people who are dying so they don't feel the need to go on to assisted suicide or euthanasia, medicalized killing? Pain control, very important. Principle of double effect, obviously. clarifies a lot. It certainly clarified a lot in my life. It made me understand what we can do. We have to be compassionate. We have to care for these people. Suffering control, hospice care. Mary's sister really benefited from hospice care. Many, many people do. We try to get as many people involved in hospice. And, you know, the hospice mantra is live until you die. You don't go into a bed and say, okay, I'm going to die. No, you try to do as many things as possibly as you can for as long as you can until you're no longer able to accomplish them. And hospice supports you in that. And they bring everything needed to support that patient. If they need hospital beds, if they need diapers, if they need what have you, they try to get it for that person. Vitally important. Social services. Care for the family. Family can really be suffering at this time as well. If we don't pay attention to their needs, we're going to be failing, and people are going to feel that the person who's dying is going to feel even more, my family is suffering. If I'm living longer, it would be better for me to be dead. So we need to do better on all of these aspects of things in order to minimize the drive for medicalized killing. What can we do in the future? Well, first, what we're doing tonight, educating ourselves, getting to our legislators and telling them under no circumstances do we want what they're having in Oregon and Washington. By the way, Oregon has just passed a ruling saying that, you know, they're waiving their residency requirements. So for them, medically assisted suicide is going to be a growth industry. You can go there, you can get off as soon as you show up. You don't have to live there for 60 days, 90 days a year. Oregon is the first state, it won't be the last. So those are major concerns. Just as there is a pro-life amendment or a pro-life law coming up for Pennsylvania, we have to look at the opposite end of things. We have to talk about end-of-life care as well. We have to be vigilant with our state legislators that we do not want anything to do with medically assisted suicide or with euthanasia, active or passive. It's all bad, and it takes focus away from the patient. That's one of the big problems I had with Obamacare. It took the focus away from the patient and focused on the economics. And when you become a statistic, you're no longer a human being. And then your life is forfeit, because if I spend money to save you, there might be 50 or 100 vaccinations I can't give children. I've heard those, and you've heard them as well during the Obamacare debates and everything else. So the economics of things can be vitally important. So we have to get into our legislators. We have to become evangelistic about this with our community as well. People that hear about this, they need to understand how evil this is. We're all facing these concerns. We educate the medical community. Sometimes difficult, sometimes not, but the medical community can be as ignorant as anybody else. I was ignorant of it until I got into the practice of it. Thank God there was somebody there to teach me, and I got interested and I educated myself. Social services. This is a biggie. If we don't get better social services out there for people, if we don't do better hospice care, we're going to run into problems, because people are going to feel as if they don't have a choice. Better hospice, end-of-life care, and last and first, political action. Not only a local level, state level, it has to be a federal level. I'm sure that Congressman Kelly would certainly be all for this. I think that, certainly Toomey, and God willing, another Republican after Toomey is gone. Casey's probably a write-off, I'm afraid to say. I had an interesting communication with him over the recent things about gender dysphoria, but we won't go into that today. So, you all know who that is. Yeah, that's Margaret Sanger. When one of our daughters wanted to look at colleges, we brought her to Chatham College, which is a small, beautiful campus right across from Pittsburgh. And we walked around and said, boy, this is pretty cool. It's an all-girls college, very nice. Until we ran into the Margaret Sanger Pavilion and the auditorium. It looked like a shrine. And they had a statue there. Oh, she's wonderful, and we walked right out. So beware. But that's know that enemy. So I'm going to stop there, although I do have other information. I don't think we need to bore anybody else. I'll open it up for questions, comments, concerns, rebuttals. Go have at it.